I'm Amy. I am a Corporate Improvement Advisor at Manchester NHS Foundation Trust. So my day job is helping people to test small change to improve the way that we work. I've been fortunate this last year to be a pre-doctoral fellow with ARC-GN, and I've been exploring the topic of psychological safety and improvement capability, specifically in our administrative and clerical teams. So before I go on, and I will go on guys, may need to be stopped, just give me a show of hands, anyone that's ever interacted with an admin and clerical professional in the NHS. Be it on phone, face-to-face, so pretty much all of us. So that's just to highlight that this topic is absolutely relevant to the way each and every single one of us experiences our healthcare. So the reason that I chose this topic is for that reason. It's really important. So admin and clerical staff actually make up around about 21% of the NHS workforce, and at Manchester Foundation Trust we mirror that number thereabouts. And we know that these staff are absolutely essential to patient access and experience. We know that they're also essential to coordination, patient flow, and we mentioned earlier the massive impact that they have on patient communication. It's enormous. Yet their experiences of psychological safety in the workplace are little explored, very under-examined. Psychological safety, in its simplest term, can be defined as the belief that it is safe to speak up and take risks in my workplace. But we know that this staff group are really underrepresented in the research that exists. So lots of stuff out there on psychological safety, loads on improvement and improvement capability, but not for this staff group in particular. So why does this matter? Well, not just because it affects every single one of us, but understanding this dynamic is actually meaning that without understanding psychological safety and without these staff being in those safe environments, we're excluding them from the improvement culture that's needed to achieve safe, effective healthcare for our populations. So there's a huge evidence gap. A scoping review was conducted as part of this pre-doc process. I personally screened 912 documents, whittled down from thousands of articles, and none of them explored this topic specific to NHS admin and clerical staff. Non-clinical teams in general remain largely absent from organisational learning and improvement research. But what does this mean? It means there is operational relevance. We need to understand how these teams work, but there's also a strategic opportunity. So MFT could actually lead research for inclusive improvement policy in this area as the biggest trust in the country. So there were 4 questions I felt that needed to be explored to provide some clarity to help my organisation to best understand how we support this element of the workforce moving forward and to inform a potential PhD effort for me. So I wanted to know what's already known about psychological safety as an enabler for improvement capability in this workforce in the NHS. I wanted to understand if there were gaps in the research. I was really keen to understand what the current state of psychological safety and improvement capability were in these staff groups in my trust, and I wanted to know if there was a relationship between the two things. So, how did I go about looking at this? Well, I explored these questions in a number of ways. So firstly, a scoping review. So I looked at literature, including grey literature from the last 10 years, so that's from 2015 to 2025. I followed the PRISMA guidelines to identify UK research on psychological safety and improvement capability in admin and clerical staff. All PRISMA means, guys, is that I did it properly. Secondly, I did a very small sample audit at Manchester Foundation Trust. So I gathered 201 responses from my admin and clerical colleagues. And I used Edmondson's 7-item psychological scale to explore their psychological safety. And I use this because this is the most valid and reliable tool that's been used in the field so far, so we know it's dependable. But when I came to explore the improvement capability element, there wasn't one tool that looked at all the different dynamics of quality improvement that I needed. So I developed a 10-item question for myself that was pulled from 5 existing frameworks. And that multi-tool was constructed to make sure that I was able to capture those different dimensions of quality improvement and how it felt for people out there in the workforce. I also, as well as the quantitative analysis, so looking at the numbers, seeing what the stats said, is this significant or is it not? I also did some thematic analysis on the open-ended comments that were collected from colleagues as well to get a bit more depth on that experience. So what did we find? Now, I was shocked because I thought there'd be something, but there wasn't anything. So 912 papers, guys. If anyone's ever done scoping reviews, most of you have experienced literature review. Yeah, nothing in there, which was really surprising because I thought there'd be at least something to map. So in answer to the question, what is known about psychological safety and improvement capability in this staff group in particular, not very much. And there is certainly a gap there in the research that we can explore. Other findings showed that psychological safety at Manchester Foundation Trust was moderate. Staff did feel valued, but still often hesitant to speak up. So what we saw was they were either in one type of environment or another. They either felt really safe to speak up, or they felt they were in not in a speak up culture at all. We also found that in terms of improvement capability, that was also moderate. So what we saw was that staff felt they had a really good foundational knowledge of improvement, but they felt that there were systematic barriers to taking that knowledge to action. So limited support being cited and limited recognition as well when efforts were made. Exploring the relationship between the two things was interesting. So even though this is a really small sample, statistical analysis did show that there was a strong positive correlation between the two concepts. So what does that mean, Amy? It just means that it's important for people in this workforce to feel able to speak up, because that will affect how they feel about their ability to make improvement. So where they do feel able to speak up, they feel more able to make improvement happen. Alongside these findings, 7 themes came out of the qualitative analysis. So communication and information flow, leadership and management behaviours came up as well, staff pressures, process, governance, and systems also came up. So, based on the findings, I'm really keen to take this forward to PhD. So I will be looking to apply for PhD funding. I've learnt tons in this last year, so I just want to say thank you to my supervisors. Faye Bradley's here today, Professor Sharon Clark at the University of Manchester as well, and Dr. Laverty for introducing me to the opportunity, and everyone at ARC, as well as the senior improvement team at Manchester Foundation Trust. Hopefully that PhD will have much more of a patient involvement component, because we want to understand more about how does this actually affect patients as well, when that psychological safety isn't there for these staff. And thank you for listening to me.
Thank you very much.